Clinical data establishes a baseline for modern obesity pharmacotherapy. Patients utilizing the latest injectable therapies are achieving 15 to 22% reductions in body weight. These figures directly mirror the outcomes historically exclusive to bariatric surgery. These results are the direct output of highly engineered peptides designed to target complex G-protein-coupled receptor pathways. Long-term data indicates that maintaining these metabolic improvements requires treating obesity as a chronic biological disease that demands continuous medical management. To safely deploy these agents, clinicians must deconstruct the specific molecular architecture of these drugs, analyze their definitive clinical trial endpoints, and establish strict evidence-based prescribing protocols. Achieving surgical-level outcomes with a subcutaneous injection requires exact clinical execution. Understanding the molecular design of these peptides is the prerequisite to prescribing safely. The GLP-1 receptor primarily couples to GAS proteins. Naturally, ligands activate the adenylyl cyclase pathway, elevating CAMP to drive insulin secretion. However, pharmacological drug concentrations recruit beta-arrestin 2, which drags the receptor inside the cell, uncoupling the CAMP pathway and blunting drug effectiveness. The engineered solution is a pharmacological concept known as biased agonism. Tirzepatide utilizes this profile at the GLP-1 receptor. The molecule is specifically engineered to favor massive, continuous CAMP generation while actively minimizing the recruitment of beta-arrestin 2. By minimizing beta-arrestin recruitment, this biased signaling profile prevents receptor desensitization. The cell continuously receives the therapeutic signal, driving superior, sustained weight loss when compared to older, balanced agonists. Tirzepatide's structural design reveals further pharmacological complexity. It is a 39-amino acid synthetic peptide based heavily on the sequence of native glucose-dependent insulin-tropic polypeptide, GIP. Researchers engineered the peptide with a specific C20 fatty diacid moiety. This addition allows the molecule to bind to albumin in the bloodstream, effectively extending the drug's half-life to approximately 120 hours. Tirzepatide illustrates unbalanced dual agonism, with GIP receptor affinity comparable to native GIP, but five-fold lower GLP-1 receptor affinity. This is strategic. GLP-1 activation centrally suppresses appetite in the arcuate nucleus. Peripherally, GIP receptors are highly expressed in adipose tissue, directly enhancing insulin signaling. By engaging these GIP receptors in adipocytes, the drug directly enhances insulin signaling within the fat tissue and regulates lipolysis, the breakdown of fats. The mechanism combines central neurological appetite suppression with direct peripheral lipid modulation. This dual agonism successfully bypasses the physiological efficacy ceiling of older GLP-1 monoagonists. This meta-analysis chart establishes a clear efficacy hierarchy. Liraglutide achieves 8% weight loss, Semaglutide reaches 15%, and Tirzepatide tops the scale at 21%. Specifically, 57% of patients on the highest 15 mg Tirzepatide dose achieved greater than 20% total weight loss. The Step 4 trial tracks weight trajectory over 68 weeks to test treatment discontinuation. At week 20, patients maintaining Semaglutide lost an additional 7.9% of body weight, while the placebo group suffered a rapid 6.9% weight regain. In the SELECT trial, Semaglutide produced a 20% reduction in major adverse cardiovascular events, including cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. The sharp withdrawal regain and documented cardiovascular protections prove these agents function as vital chronic disease modifiers. Treating obesity requires lifelong clinical administration. Clinical implementation follows defined eligibility thresholds. Patients qualify with BMI over 30 or 27 with weight-related comorbidities. Clinicians must clear patients of absolute contraindications, personal or family history of medullary thyroid carcinoma, MEN2 syndrome, active pregnancy, and severe gastroparesis. Once cleared, the semaglutide protocol demands a rigorous weekly dose escalation, climbing in 4-week intervals to a final 2.4 mg maintenance dose. This step-stair graph maps Tirzepatide's protocol, escalating from 2.5 mg weekly in strict 2.5 mg increments every 4 weeks to 15 mg. Critically, the initial 2.5 mg block exists entirely for gastrointestinal acclimatization. It is categorically non-therapeutic. The intermediate doses at 7.5 and 12.5 mg serve as optional plateaus. Clinicians can hold patients at these levels to allow for slower gastrointestinal adaptation. Disciplined adherence to these strict 4-week escalation blocks is the only clinical method proven to balance bariatric-level efficacy with necessary patient tolerability. Gastrointestinal side effects account for 90% of all adverse events. Clinicians manage these aggressively through dietary portion control and temporary dose holds during escalation. Providers must actively differentiate between standard, transient nausea and the presentation of acute pancreatitis, which is characterized by severe, persistent abdominal pain radiating directly to the back. The highest-stakes patient cohort involves individuals suffering from psychotropic-induced metabolic syndrome, typically driven by atypical antipsychotic medications. GLP-1 receptor activation in the central reward centers directly overrides the metabolic dysfunction and extreme appetite stimulation caused by dopamine D2 and histamine H1 antagonism. This dashboard displays the safety trade-off identified in FDA adverse event data. During the initial titration phase, patients face an elevated risk of psychiatric decompensation, including specific spikes in insomnia, anxiety, and depression. This data mandates a clinical countermeasure. Psychiatric patients require intensive oversight, including weekly PHQ-9 mood assessments and suicidality screenings during their first month of treatment. Furthermore, the mechanism of delayed gastric emptying presents a hidden pharmacokinetic danger. It can drastically alter the absorption curves and steady-state plasma levels of narrow therapeutic index drugs, such as lithium. Dual agonists provide a highly potent countermeasure for psychotropic weight gain. However, the exact physiological mechanisms that cause the weight loss demand aggressive, multidisciplinary oversight. Current evidence secures GLP-1 and dual agonists as definitive first-line pharmacological interventions, provided clinicians master the requisite step titration and strict monitoring algorithms. The next immediate evolution in obesity protocols relies on pharmacogenomics. Clinicians will identify specific genetic markers, like the ARBR1 variant, to pre-identify hyperresponders who achieve superior weight reductions. Conversely, identifying variants like GLP-1R SER168 predicts a poor biological response. This prevents prescribing therapies to patients whose receptors resist a drug. Concurrently, an emerging pipeline of triple agonists and amylin analogs continues to progress through late-stage trials, steadily raising the physiological efficacy ceiling. By integrating deep molecular understanding with rigorous clinical execution, modern medicine now possesses the biological tools required to manage obesity at the cellular level.